final very important speaker this morning is Professor Kirsten Holven, who is the head of clinical nutrition at the University of Oslo and a researcher on FH at the Oslo University Hospital. A really warm welcome to you, Kirsten. We know that very often women are left behind when it comes to health because their focus is really on other people, children, spouses, parents, and so on. And the research world tends to actually exacerbate this by prioritizing research on men. And again, we heard about this earlier today. And this is really evident in our world, in the world of cardiovascular disease and health. You've been a key leader in reversing some of these trends over the years and focusing specifically on women. Tell us a little bit about the important milestones for you in this space over the years. Please, the floor is yours.
Thank you very much. First of all, I would very much like to thank Magda for inviting me. I'm very excited to be here. I work very closely in Norway with the Norwegian FH patient organization, and we have annual member meetings, and it's really the meeting with these patients where I get a feeling of what is their concern, what is that they want more information about, what is the questions that we cannot answer. And this has really led to new projects, research projects, because we're trying to find out so that you can answer the questions for these, especially women. So I want to go through this, the missing piece. I want to just give some examples of where we lack information. So how do I just do this one? I'm sorry. Where do I just change the slides?
Just press it here.
Oh, yeah, sorry. This one, yeah, okay. So this is just a short outline. So, well, we already know, and I think that also data from Christoph and Kanika already showed that women with FH, they are underdiagnosed and they are undertreated. Data from the global FHSC network showed that women with FH are diagnosed later, 3 years later than men. And also women with FH, they have higher pre-treatment and higher on-treatment LDL cholesterol lower. And also fewer women with FH are treated with high-intensity statin. But then moving on specifically to female life course, we have some specific transition period, like menstrual cycle. So we know from studies in the general population that lipid levels varies during the menstrual cycle. It goes in opposition to estrogen. When estrogen increases throughout the cycle up to ovulation, the LDL would then reduce in anti-parallel. And in the women from the general population, the changes are not really very big, 3 to 5%. But what about women with FH that already have elevated cholesterol? Nothing is known. There's no studies having investigated the impact of the menstrual cycle on lipid levels in women with FH. So therefore, we don't know anything about it. So therefore, Janine Rüders van Lennep from Rotterdam and myself, we started this cycle study some years ago. It's still ongoing. It's done by Janneke Mulder here in Rotterdam and Pia Bolsrud from Norway. And we include women 3 times during the cycle. We include both women with and without FH. The study is still ongoing, so I won't show any results from the whole study. But I just want to give one example, and this is a woman with FH. She was untreated at the time she participated in the study, and there really was a huge variation in lipid levels just based on the menstrual cycle. More than 1 millimole difference in total cholesterol from the early bleeding period and up to ovulation, and more than 0.8 millimole of LDL cholesterol. Of course, we don't know the long-term impact of this, but what we do know is that this impacts treatment. So just imagine, she went to the doctor here. So the doctor had the total cholesterol of 8.9 and LDL of 5.3, and the doctor treated her either with dietary advices or maybe low-dose statin, depending on age and on everything. And she comes back to the doctor here and having been reduced LDL by 0.8, and the doctor said, wow, so the treatment started, we won't give you more intensive medication because it looks like it's working. And what it's only based on that the sampling was taken at 2 different time points in the menstrual cycle. And the doctor never asked when the blood sample is taken in relation to the menstrual cycle. So this can definitely impact treatment. For some women, the variation is great. This is just my important message, because we know that from a lot of studies from the general population, variations are not big, but when we look into the women with FH, we see that it's really exacerbated. We also did a small survey, I will come back to that later, where we ask, because we go into the next phase, which is pregnancy, and the women told us, more than 50%, that they had concerns related to the use of statins in relation to pregnancy. And there were not only concerns relating to having taken accidentally statin and then becoming pregnant because they didn't know they were pregnant, but it was also concerned having taken statin prior to becoming pregnant. They don't know is there any long-term negative effect of statins, because as you know, there's been a lot of negative media attention relating to statin use. So they are really concerned about this. And very few women, they had appointment with a physician specialized in FH during the pregnancy. And that means they didn't get any answers to the questions because the GP didn't know anything about this. So I want to give an example. We made this slide in a publication earlier this year, and just to showing the difference in cholesterol burden in women with FH compared to women not with FH. So we know that the girls have high cholesterol until they're diagnosed and started with treatment. Luckily, about 8 years or something like that, birth, so they will start statins, and the cholesterol is lowered to treatment levels around 3.5. But then the guidelines as of today is that you should discontinue statin when you plan pregnancy. So then the woman wants to start a family, so she stops statin. Immediately the LDL is increased and it will remain elevated until she gets pregnant. And then actually there is an even 30% additional increase due to the physiological changes due to the pregnancy. Then after delivery, she starts breastfeeding. The LDL cholesterol will reduce. We don't know how much, but only when she stops breastfeeding and starts a statin will she reach a treatment target again. So this is really a huge cholesterol burden just due to family planning and pregnancy. So, yeah, just going. Can I go back? No. Yeah, so what is known about this? The length of these periods without statin treatment? Almost nothing. Just a few years ago, only single case report has been published. Do we know anything about the reduction in lipid levels during breastfeeding period in women with FH? Nothing. We know that breastfeeding is good for the mother, it's good for the child, so we need to know what is really happening in the breastfeeding period in women with FH. So that led us to a small pilot study, a survey that we did in Norway and the Netherlands, where we tried to ask the women how long time did they stop using statin in relation to the pregnancy. And we found that the total, what we call pregnancy-related of statin period, it's a little complicated word, was 2.3 years. And of course, 2.3 years, well, it doesn't really seem that long. But remember, these are young women. They're on average around 30 years and already having lost 2.3 years in average. But again, as you can see, the variation was huge, from 0 to 14 years without statin in a very important period of their life. We also saw that even though the guidelines say that you should stop statin treatment when you plan pregnancy, 30% had used pregnancy into the pregnancy. Most of them stopped when they most likely realized they were pregnant. As I said, 2.3 years in average. However, 20% reported more than 4 years of off-statin period in relation to pregnancy, meaning that at the age of 31 years, women had lost almost 20% of their possible treatment time. As I said, 10% did actually not discontinue statin throughout the whole pregnancy, so they used the statin throughout the whole pregnancy. And more, maybe disturbingly, is that 25% of the women that did not start statin treatment after the pregnancy and breastfeeding. Most likely because, you are home with a newborn child, maybe you have other children and you are starting a family and you have a lot of other things to think about. Maybe you ran out of prescription and there was no visit scheduled for your GP or your lipid physician, so they just stayed at home, and then maybe after 1 year, 2 years, you got pregnant again, and there's no need to start statin treatment. So these years really accumulate for the women. So then we look into the breastfeeding, and we also asked about that. Again, many had concerns about using cholesterol lowering in the breastfeeding period. We saw, both in the Netherlands and Norway, that fewer women with FH breastfed, and they breastfed for a shorter time. And they also said 22% reported that they had stopped breastfeeding earlier than they wanted to because they wanted to get back on statin treatment. So this information has led us to start a new project, which is called the FHEF project, FHEF project, and we are looking at the effect on lipid profile during the breastfeeding period. So we are recruiting pregnant women with FH at week 36, and we follow them throughout the whole breastfeeding period. It is ongoing already in Norway. We've included more than 20 women with FH. It is starting up in Netherlands as we speak, and also in the Czech Republic it will start soon. In 2 weeks we will have the final meeting with Thomas and Mikael, because they were also very interested in doing it. So hopefully in a few years we will be able to get even more information about what is happening during the breastfeeding period. So the last important life course for a woman is transition into the menopause. Again, we know some from women without FH, but again, almost nothing is known about the effect of menopause on women with FH. And as we've seen relating to both the menstrual cycle and the pregnancy, the tendencies are much more exacerbated in women with FH because they have elevated cholesterol. So I'm also very sure that when we look at the menopause, we will be surprised to the findings that we will find. So my key message is we need more information, we need to improve treatment, we need more knowledge on family planning, pregnancy and breastfeeding periods to provide better information on treatment to women with FH. So I'm reaching out to you now to help us to increase this knowledge. We are extending our pilot study to a survey across the whole of Europe. It is an online survey, it's anonymous. It takes approximately 15 minutes to complete. It has already been translated to 16 European languages in addition to Vietnamese. So please, our aim, very ambitiously, and this was actually the whole idea of the European survey was sprung out of a meeting with Magda and Janine and myself, and Magda is always being enthusiastic, saying, well, let's aim for 1,000 women. Let's aim for 1,000 women. It's only 40 to 50 women per country. This is feasible. Let's do it. And we've done it, but so far we have had very little success in countries outside Norway and Netherlands. And I'm sure that the other countries, they're not there. You are as keen as Norway and Netherlands to get information about this. So please, I'm reaching out to you now. All the patient organizations, the clinicians, please spread this information in your network. Please help us to recruit women to fill this online questionnaire. Because this information is important. It has already led to changes at the lipid clinic regarding follow-up of the pregnant women with FH. So this information will lead to better treatment. So together we can make changes and improve treatment for women. Even despite of the trees, I've printed out a few flyers, so you can come to me and get some copies if you want to know. If your country was not among the languages already translated, please reach out again and we can facilitate translation into other languages as well. And this is just a QR code. You can directly go into the survey if you take I'll just leave it a little bit. And again, just I want to acknowledge again Magda, because really it was in a meeting. We set this ambitious goal of 1,000 women. I still think it's feasible. And of course, I want to thank Janine Ryders van Lemmet, my long-time close collaborator and partner in crime. Marianne is the one responsible for the survey. She's the one who put all these translations into the survey. She will also be the one to analyze the data. And Jannik is responsible for the cycle study in Rotterdam. Thank you.